Hello, this is Dr. Michael Niederman. I am currently Clinical Director and Associate Chief in the Division of Pulmonary and Critical Care Medicine at New York Presbyterian Weill Cornell Medical Center and Professor of Clinical Medicine at Weill Cornell Medical College. Today, I would like to talk to you about lessons we learned during the treatment of COVID-19 in New York City. We summarized this experience in an article in Respirology several months ago. This was a description of our experience in treating over 1,300 patients with COVID in our hospital between March and May of 2020. We took the position that COVID-19 has forever changed the practice of pulmonary and critical care medicine in our hospital and I think around the world. It's had a number of impacts on outpatient care, inpatient care, and medical education, which I will try to discuss in this presentation. In outpatient medicine, an awareness of COVID and the need to provide care has first and foremost led to a rise in the use of telemedicine. This may be a good thing, but may have other implications for our patients and the patients that we are treating with other diseases. For example, doctors and patients may be afraid to be taking care of other respiratory problems, and some patients may be not coming to the office and neglecting their care for their other chronic respiratory problems. Also, in an outpatient setting, we deal with multiple COVID sequelae, and we need to better understand these sequelae as we provide care to our patients. We deal with symptoms of cough, dyspnea, unexplained lung infiltrates, often due to organizing pneumonia, and the need for oxygen in patients who may even have a clear X-ray may be related to pulmonary vascular disease. In addition, there's great need to provide outpatient organized care for patients who've had COVID, particularly those who had COVID in the ICU, where they have multiple needs for a multidisciplinary care team dealing with not only their lung problems, but their psychosocial problems, the post-traumatic stress of illness, and a myriad of other family and economic issues that arise in COVID patients. We know that many patients who've had COVID have persistent symptoms long after the infection. In this study, for example, looking at 143 previously hospitalized patients in Rome, 87% had at least one persistent symptom 2 months or longer, and at least one symptom more than a month after discharge. 32% of patients had one or two symptoms, and 55% had three or more symptoms. None had fever or signs of an acute illness, but the most commonly reported symptoms were fatigue, dyspnea, joint pain, and chest pain. On the inpatient side, we've learned a lot, and it too has changed our practice of medicine. We've redefined what is an ICU. In our hospital, we had a number of pop-up ICUs when we cared for over 240 mechanically ventilated patients at the peak of the crisis. And we realized that an ICU involves skilled staff and certain equipment, but it may not be the traditional ICU that all of us have been used to. We took care of patients with multidisciplinary teams with different responsibilities. Our ICU teams consisted of hospitalists. They consisted of internists, surgeons, as well as critical care specialists. We also incorporated critical care specialists from other disciplines, including neurologic critical care, surgical critical care, and all of these people worked harmoniously to provide care for these complex patients. We developed specialized teams to do specific procedures. For example, proceduralists, surgeons, and anesthesiologists did central lines. Intubation was done by an intubation team that consists of anesthesiologists and nurse anesthetists, and we did proning of our patients with the help of physical therapists. The therapy of acute lung injury and ARDS has changed. We found patients with ARDS who had low lung compliance, but patients with normal lung compliance, which may imply a degree of pulmonary vascular disease. And the strategies for mechanical ventilation were adaptations of the traditional low tidal volume ventilation that we use for traditional ARDS. We learned how to optimize the care with non-invasive ventilation and high flow nasal cannula, we worked in ways to provide care for patients with multiple organ failure. Many of our patients had neurologic injury, kidney injury, as well as lung injury and cardiac injury. And integrating care with all of these sometimes competing illnesses was very difficult. Most notably, for example, it was difficult to ventilate patients without sedation. It was difficult to take care of hypercoagulable patients without anticoagulation. And we knew that these patients were also at risk for stroke. And if you think about the challenge of taking care of a sedated, anticoagulated patient at risk for stroke, it's possible that without careful sedation, vacations, and evaluation, the patient could have a silent stroke because of the presence of sedation, and it's important to be looking for that. And we also learned about the enhanced importance of viral community-acquired pneumonia, particularly something we were learning about in recent years that became much more clear in patients who have COVID. Our ICU team prepared this article for the Blue Journal about hospital preparedness, and they talked in this article about ways to adapt infection control. We changed some of our decisions about when to intubate. We had different airway management. We had to educate families, and we had to do patient care without visitors being allowed in the hospital as in the past. We had to adapt a variety of different environments for our surge of patients, including even the use of the operating room as an ICU. We had changes in physician staffing models that I mentioned, and we had a variety of ethical dilemmas to deal with. And of course, we had to deal with staff wellness and the emotional stress on the doctors and staff in taking care of these critically ill patients. Medical management of ARDS and COVID patients is on the one hand, like it's always been, with focus on low tidal volume ventilation, but there's been an increased reliance on prone ventilation, certainly a balance between conservative fluid management and maintenance of blood pressure, and using higher versus lower PEEP strategies was discussed. Using of neuromuscular blockade, maybe more than usually, avoiding de-recruitment when we have to transfer patients for transport, using inline catheters for airway suction, sometimes the need for extracorporeal membrane oxygenation, and even ways to use non-invasive ventilation and high-flow nasal cannula to try to minimize intubation as much as possible. We tried to prevent complications in the critically ill, complications like ventilator-associated pneumonia, deep venous thrombosis, catheter-related bloodstream infections, pressure ulcers, stress ulcers, and again, all of this was just a refinement and adaptation of standard critical care principles. COVID has changed medical education. Many of our conferences like this one are done via the internet. When we do our training program recruitment, we now interview trainees via the internet. And one of the questions we've asked is, will this experience with COVID make our specialty of critical care more or less appealing to future generations of doctors? On the one hand, we're at the center of attention and with the most exciting care. On the other hand, there's tremendous emotional stress and tremendous hard work that we have to do to take care of these patients. And so we have to focus on work-life balance, family life, and again, the emotional stress of working in the ICU. So I think we've learned a lot during COVID, a lot that's going to serve us well in managing patients in the future. But I do think that we've definitely seen changes in care as a result of COVID that will persist into the future and be forever a permanent change in how we provide care. I'd like to thank you for listening today and for being part of this conversation.
Good afternoon and greetings from Australia. We're delighted to speak to our friends across South America about the story of the global view of COVID. This is a global condition, and the rationale behind this consortium that many of your colleagues have been so generous is that in a global condition, we do need a global. Our consortium really started as the president of the Asia Pacific ELSO when our colleagues from Asia Pacific were in touch about the concerns and what to do next, and I was asked if I had any advice, and unfortunately here in Australia we'd seen very few cases and we couldn't give advice. So we started really creating a data gathering across the Asia Pacific region, but bit by bit as the epidemic became a pandemic, we grew way past Asia into Europe, into North and South America. We now have almost 400 hospitals across 54 countries looking at bringing all the data of ICU patients together to give us a picture of how these patients are managed and perhaps an idea to clinicians of how. As I say, this kicked off on around about the 1st of February, and bit by bit this map shows how rapidly the global intensive care community understood the purpose, understood the importance of a global data picture, and came together such that this is the picture that we have now. And it's fantastic to see South America so well represented. We'd be delighted to see even more. The static map shows that we have a very, very large presence, relatively little across in Africa, although that's mostly associated with lack of data collection over there. So we've got almost 3,000 patients, full in-depth data. We started with a data CRF of about 360 points day one and then 150 each day after. But that was too much data for our colleagues across the world in the middle of a pandemic to collect. And it became really an evolving process. And this picture shows the evolution really from the middle of January, where we had actually started the study even before the virus had been identified or named. But moving from the start of February to October, we've got over 2,500 patients of high-end quality granular data on all aspects of intensive medicine. Running something like this across the globe takes a huge leadership steering committee, and we're very, very fortunate that our steering committee is so powerful, representative of all the countries and all the states across the world, and with a very good male-female mix as well. Our initial plan was really just to do a central study, but bit by bit, more and more we realised that there were sub-studies. There was different things that were happening in the brain or the kidneys. There were different aspects of ECMO treatment. So from the main picture of the study, small subgroups grew into all these pictures here, whether it was cardiac, neuro, ECMO, coagulation, data acquisition, kidney, or perhaps most importantly, the long-term study. A really nice point about this was that different groups would come to us with different questions, for example, in neurology. And rather than have 50 different studies with limited power, we spoke to the clinicians and said the power of a global collaboration is working together. Let's do these studies together rather than isolation. And the neurology side of things is working through Italy and the US, and Johns Hopkins and Australia is a great example of how we will do this. And multiple questions come up across people with a specific interest in the neurology of COVID, which we think is going to be a major area. And these are some of the primary and secondary outcomes that we're looking, identifying the type and the incidence of neurological complications. And then subsequent to these observational studies, there may well be interventional studies. In a similar way, ECMO initially was not used, did not have great results across Asia Pac, but it seems much more realistic that the ECMO has a much better use here. And we have a sub-study group with a number of different studies, as well as one key study led by Eddie Fan, who will essentially do a propensity score analysis of ventilation and ECMO and whether one or other does better. Rakesh Arora in Canada is leading the cardiac sub-study group with a whole number of different aspects. We know well that patients with cardiac disease have a worse outcome with COVID. So we're trying to assess this in terms of imaging, in terms of what the antivirals do to cardiac function, looking at an artificial intelligence aspect of echocardiography, and also the use of VA ECMO patients. As I mentioned briefly before, the long-term outcome of COVID is really not known. This is a disease that did not exist 8 or 9 months ago. We are seeing patients with long-term problems, and we again started this study in February, just after a month after it started, and it's been run by a Swiss intensivist, Dr. Karen Well, to look and see what happens up to 2 years afterwards in terms of patient outcomes, whether it's health-related quality of life, pulmonary function, and organ dysfunction. And these are the inclusion and exclusion criteria. Essentially, anyone that's included is anyone over 18 that went to intensive care and that consents and is likely to proceed. Our calls happened every week at the start, and it was fascinating to have the input of so many great global leaders. As you see, we've had a number of people from South America and North America, and it gives us a really global picture, and each place was different. And it was, again, in our own centre in Queensland, we've been very fortunate that we do not have a lot of cases, but it was fascinating to hear each week. And it, as well as behaving as a data sharing time, it was a time that our intensive care family came together and listened to each other. So we were keen not only to produce publications, that really wasn't it. Our key plan was to create a dashboard so that we could take aggregate data from across the world, from all the different centres on all aspects of intensive care, physiology and management, and bring them together. And by taking these jigsaw pieces from around the world, bring them together, 10, 20,000 pieces of data, and create a picture which would assist clinicians create a picture of what may happen to their patients. And universities work well in IBM to create this dashboard, which is where we're at now, where we can look at a patient flow and outcome by creating these Sankey diagrams, so that you can create a scenario. For example, you're at 2 in the morning and you're faced with a patient in bed 3 whose PaO2 is 60 on 80% oxygen with a creatinine of 200, and it will build scenarios based on the other 5 or 10,000 patients that we eventually hope will be. And it's got incredible power. Currently, we're just working through the data that we've got in there. As I say, we've got 2,500 patients. But one of the areas we're looking at most acutely is ventilation management. This is one of our first papers. And we've got about 1,000 patients in this study. We closed the data analysis at 1,000 patients. And the mortality of the ventilation patients is obviously different. Survivors had a lower chronic cardiac disease, lower rate of diabetes, etc. If we look specifically at the ventilator settings, differentiating between non-survivors and survivors, those non-survivors at kickoff had a higher FiO2, lower PaPi ratio, lower PEEP, but at kickoff had no difference between PCO2 and compliance. If we start to look at our data, and these are unpublished data, and please don't take pictures of these or put them on Twitter, the key aspects are really this, that the PaPi ratios were not too dissimilar at kickoff. The survivors ascended the PaPi ratio much more rapidly. The the pH at day 0 was not dissimilar, but survivors' pH recovered much more rapidly throughout. And the PaCO2, again, was not too different at the start of ventilation, but those who cleared their CO2 more quickly in the lower line had the lowest PaCO2, improved outcomes. So a very brief summary of what we're doing, but I think what we've tried to do, and we're not there yet, is bring a global family together through a time of difficulty, through a time of isolation and quarantine, and we have created a global family of 54 countries and almost 400 hospitals. We can get so much stronger with the more data, and when we add one hospital to another hospital, it doesn't just equal 2 hospitals, it actually multiplies the amount of benefit that we can provide to the global community. So I would finish my talk. Thank you for your interest. Thank you for South America joining so heartily. Please be part of the global community. The data remains your own. You can publish any of your own data as you wish, but it has additional benefit by putting it into the global pie, so that together we can result in improved outcomes in this terrible pandemic that we've never faced before and we're unlikely to face again. So please join our calls. He's on the fortnightly time, and we wish you very well. Obrigado.
Thank you for inviting me to participate. I'm going to speak on pneumonia and HIV infection. I'm going to give an overview on the updates on challenges and differences in the diagnosis and management of three major causes of pneumonia in people living with HIV that are the most common causes worldwide, namely community-acquired pneumonia, pneumocystis pneumonia, and tuberculosis. Consider briefly some emerging data on COVID-19 in people living with HIV, and conclude with some considerations for non-resolving or worsening pulmonary infiltrates, including immune reconstitution inflammatory syndrome in people living with HIV. In terms of the risk for opportunistic infections in HIV infection, really the hallmark of immunocompromise in people living with HIV is the systemic decline in CD4 cell count that occurs with HIV infection, particularly when it is untreated. There's an initial depletion of gut mucosal associated CD4 cells after HIV infection that really never fully recovers. And then as the systemic CD4 cell count decreases, there's an increasing risk of opportunistic infections. With initiation of antiretroviral therapy, the CD4 cell count increases, which can be associated with a risk for IRIS. But even when the CD4 cell count recovers, there can be a persistent risk for inflammation and immune dysfunction, even in patients who are virally suppressed, that contributes to risk for opportunistic infections, as well as comorbidities. In addition to these abnormalities in T cells, there's also abnormal innate and other adaptive immune responses that contribute to risk for opportunistic infections in those living with HIV. In terms of evaluating the HIV-infected patients who present with acute pneumonia, there are three major categories that provide clues. One is the patient's history. What are their risk factors? Is this an injection drug user? What are their exposures in terms of travel history or residence, in terms of risk for endemic fungi and mycobacterial disease? And are there clues on physical exam of extrapulmonary disease? And are there any biomarkers or evidence of extrapulmonary disease, again, on laboratory testing? The most recent CD4 cell count will provide the strongest clues in terms of their risk for opportunistic infections, as we'll see on the next slide. And the chest imaging pattern also will direct the evaluation. So it's important to recognize that the risk of complications in people living with HIV varies by the CD4 cell count. At any CD4 cell count, HIV-infected patients may experience the same non-infectious complications as those who are not infected with HIV. And at any CD4 cell count, HIV-infected patients have an increased risk of non-Hodgkin lymphoma, bacterial pneumonia, community-acquired viral pneumonias, as well as tuberculosis. However, as the CD4 cell count decreases, the presentation of tuberculosis changes, the risk for bacteremia in association with bacterial pneumonia increases. At a CD4 cell count less than 200, patients have a substantially increased risk of pneumocystis pneumonia and cryptococcus, and below 100, an increased risk for other fungal infections and Kaposi sarcoma. And at a CD4 count of less than 50, increased risk for non-tuberculous mycobacteria and CMV. So in general, I recommend pursuing a definitive diagnosis to determine the etiology and target therapy for pneumonia in people living with HIV infection. And this is for multiple reasons. One is that the presentation and imaging patterns may vary by CD4 count, and the clinical features and radiographic findings can overlap. Thus, an empiric diagnosis may often be incorrect. In addition, more than one infectious process may be present in 10 to 20% of patients in many epidemiologic studies of pulmonary infections with people living with HIV. In addition, knowing what you're treating can spare unnecessary exposure to potentially harmful medications. However, this must be balanced against feasibility and the risks of pursuing a definitive diagnosis, particularly if an invasive procedure such as bronchoscopy is required. So depending on the setting, the resources available, and the patient status, empiric therapy may end up being the safest and most feasible thing in some cases. So let's contrast our three common causes of pneumonia in people living with HIV infection. Bacterial pneumonia most commonly presents with a more acute onset and purulent sputum, and again at any CD4 cell count in people living with HIV. Risk factors are similar as in uninfected patients with smoking, injection drug use, and comorbidities increasing the risk for bacterial community-acquired pneumonia. Typical chest X-ray is a lobar opacity. Pneumocystis pneumonia, in contrast, it has a more subacute and indolent presentation with 2 to 3 weeks of dyspnea and typically a dry cough. Pneumocystis is rarely seen with a CD4 cell count above 200, but the risk goes up substantially in those with a CD4 count below 200, particularly if they are not on prophylaxis. A history of thrush and prior pneumocystis increase the risk for PCP. Typical chest X-ray pattern for PCP are bilateral diffuse alveolar opacities. TB similarly presents in a more subacute fashion in people living with HIV, can have fevers, weight loss, and night sweats, and signs of extrapulmonary disease. Again, TB, the risk for TB is increased at any CD4 cell count in people living with HIV. Risk factors, again, also are similar as in uninfected patients, and the presentation on chest X-ray depends on the CD4 cell count, as we will see coming up. In terms of the recommended microbiological workup for community-acquired pneumonia in people living with HIV infection, it depends on the setting, similar to uninfected patients. So in the outpatient setting, most testing is optional. However, now with SARS-CoV-2 circulating, testing for this is recommended in any setting, and also testing for influenza in the outpatient setting if it is circulating. In the inpatient setting, because the differential diagnosis is broader in HIV-infected patients and the microbiologic yield may be greater, particularly in those who are more severely immunocompromised, sputum, gram stain, and culture, as well as blood cultures, are recommended in the inpatient non-severe as well as severe setting. Strep pneumourinary antigen is optional or is recommended in the inpatient non-severe and severe setting, similarly with Legionella urinary antigen. And SARS-CoV-2 testing, again, is recommended, as well as influenza if it is circulating in the community. However, when considering a microbiologic workup for bacterial community-acquired pneumonia, at the same time, you should be considering, does this patient have risk factors for tuberculosis or any other opportunistic infections in this setting, and pursue definitive workup for those causes as well, depending on the patient's risk factors, their CD4 count, presentation, and their chest radiograph, as discussed. So there's an interest in biomarkers to try and help diagnose types of pneumonia, or whether pneumonia is even present in people who are not infected with HIV. Using these tests, however, in people living with HIV infection is a little bit more complicated given the broader differential diagnosis for community-acquired pneumonia in these patients, where patients may present from the community with not just bacterial community-acquired pneumonia, but pneumocystis or tuberculosis. So a couple of studies that have evaluated the use of CRP and procalcitonin in patients living with HIV suggest that it does not discriminate very well between these three different common causes of pneumonia. And in fact, although there were significantly higher levels of C-reactive protein and procalcitonin in HIV-infected patients who had community-acquired pneumonia, here shown in the middle of these graphs, there was substantial overlap in the values. And when looking at the receiver operating curves, the area under the curve for CRP and procalcitonin was only fair to moderate at best in these different pairwise comparisons. Thus, really C-reactive protein and procalcitonin don't adequately discriminate between the types of pneumonia that are common in people living with HIV infection. In terms of management of community-acquired pneumonia in people living with HIV, this is generally similar as in uninfected patients. Evaluate for risk factors for Pseudomonas and MRSA. If TB is suspected, avoid using fluoroquinolones alone. Similar to HIV uninfected patients now, monotherapy with macrolides are not routinely recommended due to growing rates of resistant pneumococcus, and would particularly avoid monotherapy with macrolides if a patient is already on a macrolide for MAC prophylaxis. In terms of treatment location, the use of the Pneumonia Severity Index, or CURB-65, appear valid in people living with HIV infection, although this is mostly based on observational and retrospective data, but not on randomized control trial data. So shifting gears to consider pneumocystis pneumonia, still calling this PCP, as do the HIV OI guidelines in the United States, although many people have shifted to calling it pneumocystis PJP for pneumocystis jirovecii pneumonia. PCP can present in a variety of different ways. The middle panel here showing the classical bilateral diffuse infiltrates, more unilateral pattern on the left, and presentation with a pneumothorax on the right. In terms of pneumocystis diagnosis, stains for pneumocystis remain the gold standard, but performance of this in different laboratories can be quite variable. And induced sputum is usually the first test obtained, but again has a varying sensitivity, ranging from 40 to 70% or more, but the specificity is really very high. If an induced sputum is negative in evaluating an HIV infected patient for pneumocystis, then the next test would be a bronchoscopy with a bronchoalveolar lavage, and that has up to a 98% sensitivity for diagnosis of pneumocystis in HIV infected patients. However, PCR is replacing stains in many laboratories and can be far more sensitive to detect pneumocystis. So this brings up the question, however, of whether a PCR positive but a stain negative patient may only have colonization. It's been debated about whether a quantitative threshold could be used to help inform this question, but given variability in dilution and copy numbers, a clear quantitative threshold has not been determined. Tests that can be helpful to exclude pneumocystis pneumonia that have a high negative predictive value in people living with HIV would be a negative PCR for pneumocystis in a bronchoalveolar lavage specimen, or a negative stain as well, and the absence of ground glass opacities on high-resolution chest CT. A biomarker that has been studied to diagnose pneumocystis is serum beta-D glucan. This appears, beta-D glucan may be a little bit more sensitive in HIV-infected patients compared to uninfected. This was a meta-analysis of 23 studies comparing the performance of beta-D glucan, generally using the manufacturer's recommended cutoff for the assay. However, I think it remains unclear whether beta-D glucan can be used alone for the diagnosis of pneumocystis. This has to do with cross-reactivity with other fungi, including histoplasma, aspergillus in Canada, and the potential for false positives, such as in people on dialysis and exposure to certain antibiotics. There's interest in using a beta-D glucan to combine it with other biomarkers, such as an elevated LDH, or possibly with quantitative PCR to help inform cut points and thresholds, and putting those together to try and make a non-invasive diagnosis of pneumocystis. In terms of PCP treatment in people living with HIV, the first line is still trimethoprim sulfamethoxazole, recommended at 15 to 20 milligrams per kilogram per day in 3 to 4 divided doses based on the trimethoprim component. Lower doses may be affected, as suggested in a recent meta-analysis, and potentially with less toxicity, but this was based on observational and retrospective data where randomized control trial data are lacking. Second-line therapy is clindamycin and primaquine, or pentamidine, which might be the preferred choice in somebody who has very severe disease and needs an IV therapy. Unlike in HIV uninfected patients, corticosteroids are recommended in people living with HIV who have pneumocystis if they have hypoxemia or an elevated AA difference. A clinical question that often comes up is what to do in the patient who has PCP and who is not responding. Generally, it's important to recognize that the condition may worsen in the first 2 to 5 days of initiation of treatment for pneumocystis. And so the general recommendation is not to change therapy in the first week or so. However, if the patient is not improving, evaluate, are there problems with the drug dosing or adherence? Is there a problem with absorption? So if there's a PO regimen, should this be switched to intravenous? Is there a second process ongoing? Is this IRIS if the patient was initiated on antiretroviral therapy as well? And if the patient didn't have a bronchoscopy for initial diagnosis, then consider pursuing a bronchoscopy now to evaluate, particularly if a second process may be present. Just finding if a BAL is done and pneumocystis, detectable cysts are found, this does not mean that the patient has resistant pneumocystis, because cysts can be found for multiple weeks out after the diagnosis of pneumocystis. And again, we don't know if these are dead or alive cysts. So therapy shouldn't be changed just on finding detectable cysts on a repeat BAL. So shifting gears to consider pulmonary tuberculosis, these chest radiographs really show more focal opacities in HIV-infected patients, where the key really to knowing that the patient on the left has bacterial pneumonia and the patient on the right has tuberculosis is the CD4 cell count. So in patients with HIV infection who have a low CD4 cell count, they are more likely to present with atypical and disseminated tuberculosis. They're more likely to have diffuse disease, like an miliary pattern that is more mid and lower lung zone, to have lymphadenopathy, and may even have a normal chest X-ray. They're less likely to have cavitation. Patients with HIV who have a high CD4 cell count are more likely to have a typical presentation with upper lung zone disease and more likely to have cavitation. In terms of the diagnostic evaluation of TB in people living with HIV, sputum evaluation is paramount, getting three sputa for AFB smear and culture. Note that people living with HIV may be more often smear negative, but have a similar culture yield to uninfected patients. Nucleic acid amplification testing should be done on at least one sputum specimen, and that can be more sensitive than AFB smear for patients who are smear negative but culture positive. Note that the expert MTB assay may be less sensitive in people living with HIV infection compared to uninfected patients, but has a similarly high specificity. In terms of the TB diagnosis in people living with HIV infection, evaluate for extrapulmonary disease. Patients, particularly with CD4 cell counts of less than 100, should have blood and urine culture sent. Evaluate on physical exam for enlarged lymph nodes. These could be aspirated to make a diagnosis. Also look for signs of serositis and meningitis. And note that pleural fluid and biopsy are more likely to be positive in people living with HIV infection who have tuberculosis. Another test that is recommended for TB diagnosis in people living with HIV is a urinary LAM. LAM is a component of the cell wall that can be detected in the urine as a point of care test, and it's released from metabolically active or degenerating bacteria. And appears to be specific for active disease, and it is recommended in hospitalized people with advanced HIV infection to improve diagnosis, as well as in people who are HIV-infected patients who are seriously ill, as defined by the World Health Organization criteria, given here regardless of their CD4 cell count. So key points in management of tuberculosis in people living with HIV infection. Treatment really is similar to HIV uninfected patients with similar drug regimens and treatment duration. It is recommended to give daily rather than intermittent treatment with directly observed therapy recommended. INH, rifampin, or rifabutin, pyrazinamide, ethambutol with pyridoxine should be given for people who have drug-sensitive tuberculosis. Rifampin, however, can have a lot of drug-drug interactions with antiretrovirals, so careful evaluation and work with a pharmacologist is often recommended. And sometimes patients may need to be given rifabutin instead of rifampin. Monitor for increased risk of liver injury and cutaneous drug reactions in people living with HIV who are started on anti-TB treatment. It is recommended to start ART early in these patients, as I will mention at the end. So a couple of brief words on SARS-CoV-2 infection in people living with HIV infection. There have been a number of case series and case reports that have come out of this, but although we really still don't know very much, I would say. And so one of the largest studies that I could find what came out of New York City and looked at 88 hospitalized people living with HIV, matched 1 to 5 to HIV uninfected patients with COVID. Generally, the HIV infected patients were virally suppressed. All of them were on ART. They were more likely to have multimorbidity and to be smokers compared to the uninfected patients. However, they had a similar presentation of COVID-19 by HIV status and also a similar severity of COVID-19. And they were equally likely to be mechanically ventilated and had a similar proportion of deaths. And this graphically shows the similar proportion of deaths, ICU admission, mechanical ventilation, and composite adverse outcomes in people living with HIV and uninfected patients with COVID-19. So stay tuned for more emerging data on COVID-19 in people living with HIV. So I'll conclude with considering what to do with a patient who fails to respond or has worsening pulmonary infiltrates with pneumonia. One is to consider, is this just a representation of the underlying process with inadequately treated infection? Is this the incorrect empiric diagnosis, or is there more than one infectious process present? Or is this a non-infectious complication that is present on top of or instead of a pulmonary infection? One consideration is could this represent IRIS? So IRIS is a paradoxical clinical worsening related to recovery of the immune system following immunosuppression. It can be due to a known pathogen on treatment as paradoxical IRIS, or subclinical opportunistic pathogen with unmasking IRIS. It's important to note that it's really a diagnosis of exclusion. It usually occurs in the clinical setting where there's initial clinical improvement from the underlying disease. ART is started at a very low CD4 cell count and initiated in close proximity to treatment of the opportunistic infection, and the patient has a robust immune response to ART. Many diseases have been associated with IRIS, with the most common being tuberculosis, Mycobacterium avium, and Cryptococcus. However, non-infectious diseases have also been associated with IRIS. And in general, there have been a number of studies that have addressed this question of when should ART be initiated when an opportunistic infection isn't present. And in general, the studies have shown that in patients who have very severely low CD4 cell counts, mortality is increased if ART is delayed. And so early ART is favored. And the general recommendation is to start ART immediately or within 2 weeks of an opportunistic infection for most cases, although there are nuances for tuberculosis, and more delayed initiation of ART is recommended if there is meningitis involved. And in fact, prednisone has been studied in preventing IRIS in people living with HIV who are diagnosed with tuberculosis and have a CD4 cell count of less than 100, where 4 weeks of treatment with prednisone decreased the incidence of TB IRIS, with most cases of IRIS occurring within the first 20 days of initiation of ART and TB treatment. So to summarize, pneumonia remains a common complication in people living with HIV. PCP, bacterial pneumonia, and TB are the most common causes, with prevalence varying by region, as well as patient CD4 cell count and other risk factors. Remember that presentation and imaging patterns may vary by CD4 count, and clinical features and radiographic findings can overlap. Furthermore, the evaluation and management should be tailored to people living with HIV, as I've tried to highlight for you. There may be differences in test performance, diagnostic yield, and the differential diagnosis for the etiology of pneumonia is broader in people living with HIV. And so again, aspects of management are also different to some extent in people living with HIV compared to uninfected. So I'm happy to take any questions at the end, and thank you for your attention.
Hola buenos dias. My name is Tobias Welty. I'm the head of the Department for Respiratory Medicine and Infectious Disease at Hanover University in Germany, and I'm the past president of the European Respiratory Society. And I want to give you an overview about respiratory infections in the immunocompromised host, with a focus on patients after lung transplantation. So, months ago, we published the first guideline paper for the treatment of community-acquired pneumonia in immunocompromised adults. Carlos Luna from Argentina and we had been part of the panel, and I will show you a number of the recommendations and will focus on what is important for patients with lung transplantation. Lung transplantation is a little bit different in terms of the kind of infection and the necessity of initial treatment. So I always want to point out what the difference is with regard to lung transplantation are. So first, what does it mean, community-acquired pneumonia in an immunocompromised host? And as you can see, these are the items which have been discussed in the panel, and solid organ transplantation is one of this. The specialty of solid organ transplantation is that calcineurin inhibitors and other immunosuppressants, including cortisone, are used in high dosages, and the highest doses is in lung transplantation. All these drugs influence T-cell immunity, so the infectious disease problems in lung transplant recipients are mainly focused on the T-cell lymphocyte system. What has been recommended in the guideline paper first, and this is also true for patients after lung transplantation, the main pathogens are the same as ever. So it's Streptococcus pneumonia as number one, also in lung transplantation and post-lung transplantation, followed by Staph aureus and Haemophilus influenza. There is a special importance of the atypical bacteria, mainly Legionella and Mycoplasma, and viruses play a major role, including influenza, but also RSV and parainfluenza. And as you can see, these guidelines had been started before the coronavirus pandemic, and the coronavirus we mentioned here had been others than SARS-CoV-2, which is of importance now, but at the moment we have to take SARS-CoV-2 into account when there is a pneumonia in a lung transplant recipient. So special pathogens must be taken into account in immunocompromised patients, and I want to point out that Pseudomonas plays a major role in lung transplant recipients. And the main reason for this is that in most of the patients on the lung transplant waiting list, or maybe not the most, but a remarkable number of them, Pseudomonas colonization plays a role. This is true for the cystic fibrosis patients, the bronchiectasis patients, and a remarkable number of COPD patients. In this, there's Pseudomonas colonization, and the recurrence of the Pseudomonas strain after transplantation is a major problem. One pathogen I want to focus on is Nocardia species. Nocardia infection is something which we recognize not often, but more often than in other circumstances post-lung transplant. It's a little bit like non-tuberculosis mycobacteria, and if you see a chronic infection which is necrotizing, you have to have Nocardia in mind. Here, again, out of the recommendation of the international guideline group, some hints what has to be done from a diagnostic point of view, and this is classical sputum microbiology, including mycobacteria, non-tuberculosis mycobacteria, fungal strains, and in lung transplantation, Nocardia species. For viruses, PCR is the major source of diagnosis, and whenever it is possible, you should try to have a quantification of the viral diagnostics, so cycle time, for example, for coronavirus, or number of copies for influenza or parainfluenza. And then there are some urine antigens for strep pneumonia, for Legionella, which play a role in the diagnostic procedure. For lung transplantation, Aspergillus plays a major role, and therefore I demonstrate in the diagnostic approach for Aspergillus, and this is in our days mainly CT diagnostics, demonstrating a consolidation very often necrotizing consolidation, and then galactomannan is the antigen test of choice. You can do it out of the serum, but also out of tracheal aspirate or BAL, and we prefer BAL galactomannan as the main diagnostic procedure. Beta-glucan is used in some countries. However, it's false positive for some of the Aspergillus species. There are a lot of overlaps with other diseases and, for example, antibiotics. So in Germany, beta-glucan is not a standard procedure. With this, I want to move forward to treatment, and primarily we have to take into account classical pneumonia pathogens like strep pneumonia. Every treatment should be focused and should include anti-pneumococcal treatment. However, in lung transplantation, normally Pseudomonas has to be taken into account, and an anti-Pseudomonas treatment is standard as empiric treatment. One of the major discussion points in anti-Pseudomonas treatment is, should we start with combination treatment, or is monotherapy enough? And this is dependent, and I will show this to you, on the resistance patterns in different countries, in different regions, in different hospitals. And then for patients with special risk factors, and the two most important ones are in the last 3 months, or antibiotic pre-treatment in between the last 3 months, multi-drug resistance has to be taken into account. And I will show you the data. Multi-drug resistance mainly occur on the gram-negative side in lung transplantation. Here data from my transplantation program, an analysis of about 1,900 patients out of the last 15 years. So normally in Hanover, we have a transplantation number of 140 a year for lung transplantation. And as you can see, for all complications in lung transplantation, about a third is infection, and in between the infections, it's half and half viral and bacterial infection, and about 20% are fungal infection. And if you look, this is an old but very often cited paper out of our program. Pseudomonas aeruginosa is ranked first, and I told you the reasons for this. And then staphylococcal disease and staphylococcal pneumonia is on the second place. And we published a number of papers demonstrating that Aspergillus fumigatus plays a big role in post-transplant infections, and I will come back to this later on. One of the problems we have in the lung transplantation program in Europe is the patients become older and the donors become much, much older. As you can see, when I started lung transplantation, end of the 80s in Hanover, the mean age of the lung transplant donors was between 20 and 25 years. And this was all traffic accident victims. Today, it's all intracerebral bleeding, and the mean age has raised to about 55 years. And in these older donors, there is a lot of pathogen colonization, which plays a role in the post-transplant period. This is one of our main slides, which is now part of all guidelines for lung transplantation worldwide, demonstrating that in the first months after lung transplantation, bacterial infection is dominating, but later on, viral infection with a special focus on CMV, cytomegalovirus infection, is coming up, and fungal infection plays a major role. Back to the treatment, this is the European guideline for nosocomial pneumonia, and Carlos Luna and I are both part of this guideline paper, and I only show this with regard to the combination therapy question. If there is a prevalence and the 15% of resistant strains is absolutely without evidence, it's an arbitrary number. However, if there is a higher incidence of multi-drug resistance, you should start with the combination therapy. In countries like Sweden or Denmark in Northern Europe with a very low resistance pattern, anti-pseudomonal monotherapy may be adequate. Well, some words to some of the strains which are of major importance. Carbapenem resistance for Klebsiella and coli is rising, mainly in Southern Europe and in Eastern Europe. And you can see here some of the alternatives to classical treatment, and what is more and more used now for CMEs in Germany is ceftazidime avibactam, because most of the ESBLs in Germany are class D ESBLs, and avibactam is very, very effective against this. And this is the main paper published by my dear friend Tony Torres years ago, demonstrating that ceftazidime avibactam is as effective as meropenem in nosocomial pneumonia. The second one is Pseudomonas, and if there are resistance problems, we normally use colistin. However, there are now more and more colistin-resistant strains, and in Pseudomonas we also have an alternative now, which is ceftolozane tazobactam, which has been shown by this paper by Marian Kolev to be as effective as meropenem in nosocomial pneumonia. And I use ceftolozane tazobactam, and under German conditions, under Middle European conditions, for Pseudomonas in a higher dosage, which means 3 grams 3 times daily. It's a very effective treatment. Acinetobacter is a major problem. It's not a German problem, but in Southeastern Europe, mainly in Turkey, it's a real problem and very hard to treat. Colistin is one of the only alternatives for this bug. But we now have new antibiotic, which is just launched in Germany, cefiderocol. And cefiderocol is a very fancy antibiotic which uses an iron-dependent mechanism, and you can see the low MICs for most of the multi-drug-resistant bugs here, and it has been shown in a not published study, it's in a review process, that it is more effective than meropenem in MDR pathogens. So my last slides are with regard to invasive aspergillosis. This is a real problem in lung transplant patients, and this is the European Society of Infectious Disease guideline published 2 years ago. In my mind, a very well done guideline demonstrating that voriconazole or isavuconazole are the drugs of choice, and liposomal amphotericin B is an alternative. The third alternative could be caspofungin, echinocandin. However, the data set for the echinocandins in aspergillosis is very weak, and it's a last chance alternative, not a standard treatment. Well, I only want to mention 2 issues for stopping. First, if you use a sole in invasive aspergillosis, you need track monitoring. That's absolutely important, because the metabolism of the voriconazole is individually totally different, and underdosing is strongly associated with mortality. So if you do not get a target level, a draft level above 1 milligram per liter, you are not in an effective concentration rate. And so drug monitoring is absolutely essential and is strongly recommended in my country. The alternative to voriconazole is isavuconazole. Isavuconazole is very well penetrating into the lung. There is a comparison study with voriconazole demonstrating similar outcome, and the advantage of isavuconazole is that the side effects, and mainly the hepatobiliary side effects, are much lower than for voriconazole. So in patients with liver problems, we prefer isavuconazole. So with this, I want to conclude. Antibiotic treatment has been specified in the new guideline published in CHEST for the immunocompromised host. It's not so focused on lung transplant patients. I told you what the special issues for lung transplantation are with Pseudomonas and Aspergillus in focus. Don't forget cytomegalovirus virus. This is something which always have to be explored, and as ever, you need an antibiotic stewardship program for these patients to streamline the treatment approaches in your hospital. Thank you very much for your attention. Keep safe, and it's a shame that I cannot be in Buenos Aires, but I hope it will be better next year or the year after, and it will be a pleasure again to be in this wonderful city, in this wonderful country. Thank you very much.